Okay, so I'm going to start letting people in now. All right. Hello, everyone, and welcome to our next webinar on life after losing your kidney transplant. My name is Sadia, and I'm one of the program coordinators at the Kidney Foundation. And we're very thrilled to have our amazing moderator and speakers be here today to share their thoughts and experiences when it comes to this transition in life. So I'm just going to go over a few guidelines before we get started. You have joined the presentation listening with your computer speaker system by default. All participants will remain muted. Participants also will not be visible on camera during the presentation. Closed captioning is available through the Teams app. Please click on the ellipsis, depending on which device you are using. Once you click on the ellipsis, select the option to turn on closed captions. For those of you who are joining from your computer, you will have the opportunity to submit questions to the presenters by typing them into the Q&A icon found in the Teams toolbar. Please feel free to enter your questions. That any that you may have throughout the presentation. Note that the Q&A is not available for all Teams versions. Please avoid using the chat box to submit your questions. It helps us to monitor them more effectively when they are submitted in the Q&A icon. So if you don't have the Q&A icon, please put them in the chats and we'll flip them over, no problem. We will do our best to answer your questions during the Q&A session at the end of the presentation. To protect your privacy, when you ask a question, please do not use your name or provide any other personal identifying information. We will collect those questions at the end of the presentation and address as many as we can. We invite you to send any further questions to ontario.programs@kidney.ca. If you are having any difficulties with joining or viewing the webinar, please email our IT support, steven.bataxi@kidney.ca. The information presented in this webinar is current as of today, Thursday, August the 3rd, 2023. Please remember that the Kidney Foundation is not offering medical advice. For specific information about your own situation, please speak with your healthcare team. This information is intended for an Ontario-based audience. I'd now like to introduce and welcome our amazing moderator for today, and that is Mr. Joseph Kim. Over to you.
Thank you, Sadia. Welcome, everyone. Really appreciate you joining us today. I think it'll be an outstanding session and highly informative. And we've got a fantastic panel of speakers. Just as a sort of an intro to myself, I am a transplant physician and nephrologist based at the University Health Network. I'm the director of the kidney transplant program and had a number of years of experience in the management of kidney transplant candidates and recipients. And so I'm really pleased to be able to moderate the session. There's 4 speakers today who will be sharing their experiences and their insights. The first will be June Jones, who's a patient partner based in Ottawa and has had experience with kidney disease for many, many years, both with respect to receiving dialysis treatment as well as transplant. And so she brings a wealth of knowledge and experience to this discussion. So I really want to thank her for joining us. We also have Sandra Bartlett, who's a nurse case manager for the London Health Science Centre, who works in their local MCKC and has a tremendous amount of experience in educating patients about modality selection, as well as a lot of experience around the management of patients in those transitions. Then we have Dr. Christine Ribick, who is the medical director of the kidney transplant program at St. Joseph's Hospital in Hamilton. She's also an associate professor of medicine at McMaster University. So she'll be able to speak from the perspective of the transplant team and address issues that are transplant specific in the context of the topic of today's discussion. And then finally, we have Dr. Vincent Key, who is a nephrologist based at Trillium Health Partners, who, of course, has a large practice of chronic kidney disease and dialysis patients, but also follows and manages transplant patients as well, and regularly collaborates with our team as well as, I believe, the SHO's team as well in terms of the long-term management. So has some very important, helpful insights from his perspective that he'll be willing to share as well. All right, so without further ado, then let's get started. So our first speaker will be June. Welcome, June. Thank you for joining us, and really looking forward to hearing your journey about living with kidney disease and your experience with transplant as well. So the floor is yours.
Thank you, Dr. Kim. Good afternoon. I'm June Jones, and I'm a transplant recipient. My kidney disease was diagnosed 35 years ago. When I went for my 6-week checkup after giving birth to my first child, I was told that I had blood in my urine. The doctor didn't investigate any further, so I didn't worry about it either. When I was pregnant with my second child, I had blood in my urine the whole time, and the doctor thought I might have kidney stones. Once my son was born, the pain went away and no more action was taken again. The following year, we were building a home, and I became extremely run down. I was overseeing the building of the house and went over every lunch hour and after work, and was trying to pack, take care of 2 small children, and working full time. I went to see my GP and told him that I had 1 week to get better before we made our move. He ran blood work and gave me a call and told me he had to send me to a specialist. That specialist was an arthritis doctor. I had been diagnosed with juvenile rheumatoid arthritis as a young teenager, so I wasn't surprised that my arthritis was acting up. From that appointment, I was told I had too much blood in my urine, and she was referring me to a nephrologist. The nephrologist started testing me for lupus, but the final prognosis was IgA nephropathy. Fast forward a few years, and my husband had accepted a job in Virginia. We decided to move our family and flew down to look for housing. When we came back, my nephrologist was on holiday, so I was seen by another nephrologist at the hospital. We discussed getting me into a good hospital in Washington, and he was going to refer me to a doctor that he knew. Everything was now set. The next time I went back to see my own doctor, she told me that we were not to make the move. She told me that I'd be going on dialysis within the year. This was the first I'd even heard of dialysis, and you can just imagine what a shock it was. I ended up lasting 2 years before going on dialysis. In May of 1998, I had the catheter inserted into my peritoneal cavity, and a few weeks later, I started in-center hemodialysis at the hospital. Once my catheter was ready, I transferred to peritoneal dialysis. PD went extremely well for me. Every 4 hours, I did a manual treatment before going to work, directly after work, before going to bed, and 1 treatment during the night. It certainly didn't rule my life. I was working full-time, taking care of 2 small children, while my husband worked late hours or was on the road, but life was going well. I was asked to speak to family members to see if one of them would give me a kidney. I have 8 siblings, so I thought my chances would be very high, and I'd have to choose which donor I'd receive the kidney from. As it turned out, all my siblings were B positive while I was O positive. My husband and cousin had come forward, but I carried an antigen that would reject their kidney. Luck was not on my side. It took me 1 month to get on the transplant list. I carried a pager with me at all times and would test it every once in a while just to make sure it actually worked. 6 months later, my prayers were answered. I remember I'd been working on a proposal at work and gone into a meeting about it. I told the team I wouldn't be around over Christmas, this is when the proposal was due, because I had asked Santa for a transplant. Little did I know that that weekend, November 28th, Santa granted my wish. I received the call, and when you know it, it was the one time I wasn't wearing my pager. I was at the hockey arena with my son when my daughter answered the phone at home and received the news. When I arrived home about an hour later, she informed me that the hospital was waiting for me to call and they had a kidney waiting for me. My life was about to change. We drove to the hospital, waited around for blood work results, and then received the news about 2 o'clock in the afternoon that the kidney was a match for me. When I woke up after my transplant, the doctor told me that this new kidney was made for me. My creatinine level was 86, and my donor had been a young man around 20 that had died of a brain aneurysm. Things went well for the first few days, and then I was told I might be in rejection. Every time I took my medication, I was sick. One of the nurses figured out the culprit. It was gravel. I was having an allergic reaction to it. Once I was taken off gravel, it was smooth sailing. I was told by one of the nurses, just take one day at a time. Me being the optimist thought, I'm not losing this kidney. I'm going to live my life. I did live my life. We traveled. I was back to living a normal life without any dialysis. In 2007, my husband and I decided to move to California for his work. Both our children were now in university, so it was time to make the move. We lived in California for 3 years. I volunteered with Habitat for Humanity and helped build 13 homes, traveled all of the states, and was able to try out different foods, although I was always careful about my sodium levels, and we just enjoyed life. I did find out just before leaving Canada that my disease had resurfaced to my new kidney. Still, I didn't think about losing it. In 2010, we returned back to Canada. I started working again, but around 2012, I started not feeling well. My creatinine level started to rise, and I couldn't keep any weight on. I tried to drink my required amounts, but anything that I put into my body just came right back up. In the end of May 2013, I was called in for a nephrologist appointment, or so I thought. When I arrived, one of the nurses came to me and asked me to go for a chat. The chat was to tell me something that the doctors didn't want to tell me. This kidney that I'd had for a few months shy of 15 years was starting to fail. After talking with her for a few minutes, I was then introduced to my new care person, a nurse practitioner. This nurse practitioner sat down with me and told me that within 6 months, I would have lost my kidney. From there, I was ushered in to speak to a social worker who discussed the different types of dialysis and asked me to speak to friends and family about becoming a donor. I already knew that none of my siblings were a match. My husband wasn't a match. Where in the world was I going to find another match? She also discussed the paired donor program that had just begun. I didn't have a match, but my donors could be part of this program and I could receive a match out of this. You can just imagine, my head was spinning at this point. My creatinine level hadn't yet reached 400, and last time it was 600 before dialysis. Within 6 weeks, I had lost my kidney. I had blood work done in the hospital on Friday, and the following Monday, I was trying to get myself showered and ready for the day. My stomach turned in the shower, and I almost fainted. I was so weak that I couldn't even blow dry my hair. I called the hospital and spoke to the nurse practitioner. She told me to get to the hospital immediately. She told me that my blood work was not very good, but I can't even remember my numbers. It was such a shock to me. She called me again that morning and asked why I wasn't on my way. I was waiting for a ride. She said that I had to go immediately and stop wasting time. I was in the hospital within an hour. It was a real whirlwind for me. I couldn't believe that I was in such bad shape 6 weeks later versus 6 months later. I was admitted to the hospital right away, and by the end of the week, the central line had been inserted to start hemodialysis. The reason I had lost my kidney was because I had drug-induced colitis and had built up a toxicity towards cyclosporin. As well, my disease had come back. I stayed on in-center hemo for 1 year, the year from hell. I started 3 days a week and didn't do well, so it was decided that maybe I should go 5 days a week and do a shorter time. This wasn't the answer either. My blood pressure was extremely high, and most days I was vomiting on the machine. The only reason I stayed on this for a year was because I had 2 people working up to become my donor. The first was a cousin, a really good match, but she ended up with kidney disease herself. The next person was my niece's mother-in-law, who I didn't think would ever match me. Apparently she was a great match. So in July of 2014, I thought I was doing my last hemo treatment at the hospital. I was asked to come into the hospital the night before my transplant, have my treatment, and then be ready for the next day. My husband and I talked about how our lives were going to change to better again, no more dialysis. Luck was not on my side again. When I was doing my dialysis treatment, the transplant coordinator came to see me. My thinking, well, listen, this nice, she's coming to wish me good luck. That wasn't the case. She came to tell me that there was an error. A strong antibody was found at the last moment that would cause me to reject the donor's kidney. The hospital was unable to get a hold of my donor and asked if I could reach out to her. My first reaction was, what in the world am I going to tell my husband? And what was I going to tell her? Those were the worst 2 calls of my life. I asked the transplant coordinator to please have the catheter inserted again so I could start PD because hemo wasn't working for me. So here I am today. After my transplant failed, I've had 1 year of in-center dialysis, 8 years of peritoneal dialysis, which I was able to travel all over the world, places such as Sweden, UK, the Netherlands, Switzerland, the US, and now 1 year of home hemo, which I've begun traveling again, first in Canada and now 2 trips to the States. International just hasn't been tested yet. But you can just imagine how going on hemo appealed to me. When I was started hemo again, the same problems started. High blood pressure, dry heaving on the machine. I was the patient that no nurse wanted. The doctors figured that maybe home hemo would be better for me. Less pressure and doing it at home. Well, to start, it didn't go well. I had 6 weeks of training, and in my final week, the doctor actually thought I was having a stroke. I was taken from the Riverside campus to the Civic campus by ambulance. Apparently, I hadn't been making any sense, and I couldn't remember my name, where I was, or my date of birth. After a few hours, I remembered everything. After further testing, it was found that I had suffered a complex migraine. Home hemo was not off to a great start, but I can say that after a year, it's going okay. I no longer suffer from high blood pressure or headaches, but every once in a while, issues arise that make me want to think my home hemo, including a water failure that just happened this morning. The benefits are that I can get up early in the morning, have my treatment, and be over by 9 or 10 o'clock in the morning and be able to get on with my day. This time around, it's extremely hard for me to get a match. I've had 16 people come forward to donate, but there hasn't been a match yet. Most of these donors have decided to go into the pair donor exchange. My antibody level's at 100%. This is due to the fact that I've had 2 pregnancies, a kidney transplant, and 5 blood transfusions over the years. Just to put this into perspective, if I was at 95% or anything less than 100%, my odds would be more positive that I would have received a kidney by now. I remember being in the clinic doing hemodialysis and looking around thinking that there are so many people here that will probably be on dialysis for the rest of their life. Little did I know that I might be that case. To this day, I still feel guilt of losing that transplanted kidney. When I first received my transplant, the transplant team would get a panel of us together to talk about to talk to various nursing staff and doctors about how we felt and what we had gone through. One of my talks was with a young woman who had had a heart transplant. One of the questions asked of us is, do you feel that the transplant organ is yours? Her answer was yes. My answer was no. I was taking care of that kidney for the person that had passed. I didn't really feel it was mine, although it was in my body. When I lost my transplant, I felt I had let that person down. They didn't just die one time, they had died once again. 1 month ago, I'd asked one of my nephrologists whether or not there was a chance, maybe if I hadn't become dehydrated, could I have saved it? Of course, her answer, to make me feel better, was no, but I still feel that guilt today. Still being the optimist that I am, research is making strides today. Someday, there might be a kidney waiting for me.
Thank you, June. Thank you for that very, very compelling and very personal story. It's not something that can be easily shared, but you've done it so masterfully. So thank you so much. I suspect there's a lot of thoughts and emotions going through the people who are on the call right now. And of course, encourage you, any of you who have any questions for June or for any of the other speakers, of course, put them in the Q&A. But thank you again, June. Really appreciate it. And of course, we'll have you back for the Q&A at the end. Much appreciated. So move on then to Sandra Bartlett, who's, as mentioned earlier, the nurse case manager for the Regional Renal Program in London Health Sciences. And she'll be sharing her experiences as one of the members of the chronic kidney disease care team there. Sandra?
Thank you, Dr. Kim. Hello, everyone. Sorry, I hope everyone can hear me. I just had a little glitch there. Before I start, I just wanted to make two quick comments to our wonderful June. June, you remind me so much of why patient experience is so important for all of our patients. Many of us who are on this panel today, we help people with kidney disease. There's a vast wealth of knowledge on this panel, but we don't know what it feels like to have kidney disease. And the things you shared today, thank you so much for sharing. And the other thing I wanted to say was whether somebody's kidney lasts 5 years, 15 years, 20 years, they come through to our failing transplant clinic. And sometimes I question, why do we call that failing? To me, that's success. Somebody has been away from dialysis and has had the experience of transplant. And I think maybe for future conversations, we can talk more about a new name for that clinic. So as a nurse case manager, my role is primarily patient education. I help patients to learn about chronic kidney disease, day-to-day self-management to slow down progression of kidney disease, as well as information about all chronic kidney disease treatment options. So at LHSC, we have a clinic specifically for patients whose transplants are declining in function to the point where another form of treatment will be needed. In other centers, it may be that patients go from transplant clinic into the multi-care kidney clinic. The first area of my presentation today focuses on how does a person living with a failing transplant feel? Do they understand what this means for them and the reality of next steps? So when I meet a patient in clinic, I have to complete a needs assessment. I can't provide education to someone until I understand where the patient's at in their understanding of their current health situation. So what I often do is I'll ask them what have they learned from their nephrologist. And I do this whether somebody is with a brand new diagnosis of kidney disease or whether somebody's undergone transplant. And it's really about starting where the patient's at. So I'll say to them, you know, what did your nephrologist tell you today about how your kidney is working? And at this point, it's really important to sit quietly and listen. A lot of times patients will tell me, well, the doctor has said that their kidney is failing and they need to come up with a plan for treatment. Sometimes I know these patients from the multi-care kidney clinic prior to their transplant, and sometimes patients don't know me at all and they're hesitant to share as no sense of trust has been established yet, and that's okay. Sometimes people want to hide their emotions or not address them because it's too raw or too difficult to share with a stranger. But some of the emotions that come through when I talk with people are sadness for a multitude of reasons. People are grieving the loss of their transplanted kidney. They're concerned about heading back to dialysis. A lot of times, you know, there's a significant lifestyle change that's going to have to be made, as well as, you know, something that June spoke to, that perceived disappointment of letting down the living donor or the deceased donor's family. Sometimes people are frustrated. They say, you know, I tried so hard to keep this kidney working and it hasn't. Sometimes people are angry, and they may be angry in clinic, they may be angry with us, but a lot of times I know deep down what's behind that anger is being scared. Sometimes people have regret. They say, you know, there were things that I could have done, that I should have done, that I just didn't do. Sometimes too, I hear some bargaining. People say, well, what can I do now? What can I do to keep this kidney working for as long as possible? And a lot of times too, I hear fear from patients because they're afraid of the unknown. Perhaps they've had a living related transplant and they've never been on dialysis, and they're fearful of what comes with that. Sometimes patients can be ambivalent as well. They just say, you know what it is, and I just have to move on. As well, I hear hope from people. They say, well, I know I'm going to need some dialysis, but I want another transplant, and let's get going on that. And sometimes people, when they've come from transplant clinic and the transplant team has worked so hard to help them keep that kidney working, that sometimes the focus of how the patient is truly feeling and their symptoms that they are experiencing are becoming overwhelming. And they say to me, Sandra, I just want to get feeling better. Can I please get back on dialysis? So it's really important in our clinic that we acknowledge people's feelings. And at that point, I can't just jump right into, well, here's some information on home treatments. Being part of a multidisciplinary team, it's really important for all of us to be self-aware and to know when it's time to recommend another team member whose knowledge and skill can better help the patient. So when I see a patient who is struggling with their emotions, I offer social work support. Our social workers, man, they're amazing people. They're highly skilled. They're members of our team who are masters at helping people work through emotions. So at that point, that may be the end of my visit with the patient on that day, because it's really important that they spend time with the social worker and have that opportunity to perhaps start establishing a relationship with that person as well, and start working through those feelings that they're experiencing. If not, if they're able to speak more with me, then I'm trying to get a sense of their readiness to learn. So I'll start talking about them about, are they ready to start learning, and what are those next steps for them? And it's really important to define that with each patient. So sometimes it's a combination of learning about maintaining their kidney function, as well as information on treatment options. So the second area of focus in my presentation is, how does a team prepare the person with a safe, healthy, and accepting transition to starting or returning to dialysis? So our failing transplant team is almost identical to the multi-care kidney clinic team. We have a nephrologist, a clinic nurse, a social worker, the nurse case manager, the dietitian, and a pharmacist. So I really highly recommend to people, if you're transitioning back into this clinic, use your team. That's what we're here for. That's what you pay your taxes for. So please use us. I know in other parts of London Health Science Centre, in other programs, they don't have a robust team like we do in Renal. So we're here for you. So please don't be shy. If you haven't met members of your team yet, ask to meet them, or one of us may likely come and try and find you as well and introduce ourselves and let you know what we're up to. So when we start clinic, we meet for report and we review our patients prior to the start of clinic. And truly, each member on our team is attuned to the needs of our patients and supports accordingly from our area of expertise. And when we do report, each one of us may have something that we want to review with the patient on any given day, but we're also flexible in that the patient may come in with their own needs that day, and we have to pause on our own, I guess, agenda is the word, and just be there and ready to work with whatever the patient presents with that day. If something does come up during clinic, with the patient's permission, we do communicate with each other and make sure that the right person is in the room providing the right care in that moment. From a nurse case management perspective, I start with introducing learning tools that are available to help people with accepting that shift back to dialysis, while perhaps also preparing for another transplant. And the combination of learning tools, it really is unique to each individual. I like to find out what the patient's previous experience is with learning about options prior to their transplant, and also finding out how they learn best. Are they working full time? Are they able to come in for an education session? Do they benefit from being in a group setting? Perhaps somebody's illiterate and can't read. So it's working through doing that, once again, a needs assessment of the patient to determine what is going to suit them best. And truly, that is the foundation of being an adult learner. Adult learners are self-directed learners. So it's important to acknowledge that and provide as many different learning opportunities for people as possible so they can acquire the information they need to make informed decisions about treatment. So some of the examples I'll share with you that we have in our program, and this really varies from program to program. We have in-person education sessions that include interactions with other patients who volunteer to speak about the treatments that they are currently receiving. Now, if people don't have that opportunity within their own program, I highly recommend contacting, perhaps through your social worker or directly through the Kidney Foundation, the peer support program that's available through the Kidney Foundation. It's fantastic. Other opportunities that exist are online web-based opportunities. We're also very big users here at LHSE of the Kidney Foundation binders, as well as their web-based education materials. We also have opportunities for patients through, not only through our patient education sessions, but also through formal referrals where patients can go on what I like to call a fact-finding mission in the peritoneal dialysis or in the home hemodialysis unit, where they can meet with a nurse and they can learn more about the home therapy and see if they can see themselves doing that in the future. I always tell people you're not signing in stone that day that you're going to do that treatment. You're just going to learn about it and see if that's something you could see yourself doing. In one of our other patient education sessions, we take patients on a tour of the in-center hemodialysis unit. And as well in that session, they have an opportunity to speak with patients about what in-center hemodialysis is like as the patients are having their treatment. So that wraps up my presentation for today. I'm going to now hand things back to Dr. Kim.
Wonderful. Thank you, Sandra. That was a fantastic overview. And I must say your patients are really fortunate to have your team overseeing their care. It sounds like a fantastic setup. We have something similar at UHN as well, but I think every population is a little different, and it seems that you're serving the needs of your population extremely well. So much, some stuff to learn there for us as well. Thank you so much. Next on the hit parade is my colleague and friend, Dr. Christine Ribbick. So Dr. Ribbick, as I mentioned earlier, is the medical director of the kidney transplant program at St. Joseph's Hospital, but she's also got a number of important leadership roles at the level of TGLN, our Treat Gift of Life Network, which is the donation and transplant organization in Ontario, as well as at Canadian Blood Services around issues related to new ways of allocating sort of difficult to match patients and so forth. So something that's somewhat germane to this discussion, or maybe more so in the next part two, which I'm hoping to sort of entice you to sort of attend as well, which will be coming up in November. Anyway, so I'll leave it to Dr. Ribbick to speak a little bit more on the transplant side of things, and then she'll be followed by Dr. Key, who will speak more on the general nephrology side. So Dr. Ribbick, the floor is yours.
Thank you so much, Dr. Kim. And I also want to thank wholeheartedly June and Sandra for really setting the stage today and giving us all many things to think about and hopefully talk about together. You know, I always say that transplant really takes a village. And that village is comprised of a huge multidisciplinary team. And at the center of that village, of course, is the patient. And hearing the patient's voice and perspective is so important. Because even with lots of time to think about the effects of kidney disease on the individual patient, even with lots of time to think about transplant and different options, it always comes as somewhat of a disappointment when a kidney fails. And I say that because, it's something that we would expect, and we're going to talk about that in a minute. We would expect the kidney is not something that is going to last forever when you receive a transplant. We know that a deceased donor kidney on average lasts for 10 to 12 years on average. But I always say that your kidney may fail within the first year, or we might be looking at your kidney lasting for over 20 years. And in some cases, I have patients in my practice that have had kidneys for 29 years or 30 years. But on average, it's about 10 to 12 years. And a living donor kidney will last longer than that. On average, we say about 15 years, maybe a little bit longer than that. But again, there's a big variability, and there's many reasons why there's that variability in why a kidney lasts so long. But the one thing that is common is that just like we are so excited, and we heard in June's voice the excitement when she received her first kidney transplant, and I am hopeful that she is going to be successful in her journey for her second kidney transplant. But we heard that excitement in her voice for her first kidney transplant. Just as she's excited, just like her family's excited, the team is with you, that village is with you, that multidisciplinary team is with you, and they're excited for that next phase. And even though we know that kidney transplantation is not a cure, the reason we're so excited is because we know that kidney transplantation improves quantity of life for the majority of individuals, not everybody. And we know that in those that are elderly, particularly over the age of 65, it may not improve quantity of life, but it will improve quality of life. And that's why this is such a celebration. We know it is likely not going to be forever. And despite knowing this, and despite hopefully communicating this clearly, part of the human spirit is always to hold on and say, but maybe I'm going to be the one where it lasts 30 years or more. But on average, we know that is not the case. So when we see a kidney is not stable, kidney function is not stable, and there seems to be deterioration or that really uncomfortable word where we see it's failing, just as June expressed that immense guilt that she felt. And, I'm really trying to highlight that, as much as we can tell you that you shouldn't feel that guilt, I really want to drive it home one more time. Your kidney actually lasted longer, almost 15 years, you said, a little bit longer than average. And that's probably because there are a multitude of reasons, but probably also because, you did all the things that you needed to do. And there are some things that can happen with kidney failure and kidney transplant failure that, regardless, if you do everything that you're supposed to do, take your medications, do your blood work, come to clinic, do everything that you're supposed to do, it's still going to happen. And just as you felt that guilt, there's always this element of guilt on the side, believe it or not, of your village, of your transplant team, where, although we are always going to be open and honest and transparent about what's going on, just like we're celebrating at the time of your transplant, we know that the next phase of your journey in going back to dialysis and looking for the next transplant is one that, we feel some guilt about, even though it may not be founded in, a reason to feel guilt, just like June expressed. So I kind of wanted to provide that lens, because I think often as healthcare providers, it's always nice when we hear so candidly and openly the personal stories from patients. It's nice to feel like we're in a safe space to share kind of how we feel during this journey. So June mentioned some very important things. She mentioned that she lost her kidney, or her kidney failed because she had recurrent disease. IgA was her initial disease. And she also mentioned that there was some toxicity from one of her medications because she was having some gastrointestinal issues. And in fact, this is one of the things that can happen after transplant. In fact, when we look at how people, lose their kidney transplant or their kidney transplant fails, 50% of people will die with a functioning kidney. So there will be something else that occurs, and that kidney transplant is still functioning at the time of death. The other 50% of people, there's a kind of, a myriad of reasons why their kidney might go on to fail. And the biggest group is something that we used to call chronic allograft nephropathy, and now we call interstitial fibrosis tubular atrophy. Big words, but I'm going to give you the gist of what we're talking about. What's happening is that over time, the kidney is becoming more scarred and having difficulties with maintaining the structure that we should see for a good functioning kidney. So this is related to sometimes immune things that are occurring, causing ongoing damage to the kidney over time. Because for the rest of your life, for your kidney transplant, your immune system is saying, there are differences between myself and this kidney. And because of that, there could be some immune recognition of the kidney. So that usually happens in the 50% that are left. That happens to in about 30 to 40% of the cases. We talked about recurrent disease. Like June mentioned, she had a recurrent IgA. IgA, we're not going to get into all the details of every single recurrent disease because there are many. Typically, IgA, we would see recurrent IgA in many people that have IgA in a kidney transplant if we were to do a biopsy. In fact, up to 40 to 60% of people could have IgA again in the transplanted kidney. But this doesn't usually lead to loss of the kidney. It can, but not in all cases. But there are other recurrent diseases that maybe the person had that caused them to have kidney disease in the first place. That can come back in the new kidney. And one particular one that we think about is something called FSGS. And that can come back depending on the type of FSGS in 40 to 60% of cases as well. And that can result in loss of the kidney, sometimes as dramatically on day one after kidney transplant, we can see the disease actually coming back. So that kind of, when we think of, disease recurrence, it's probably in about 10% to 15% of people leading to graft loss. So what are other things? You can have a new disease. So believe it or not, people can sometimes develop a completely different disease of their kidney that can cause graft loss. And then, the remaining causes are rejection. So there are really two forms of rejection that we think about in kidney transplant. There's antibody-mediated rejection, and there's something called T-cell mediated rejection. In Canada, we've done a really nice job of collaborating. So our villages talk to each other, which is really nice because we've really formed a really broad community across the country. And we know that our rejection rate across Canada is somewhere around 11 to 13%, which is actually much lower because I remember when I started in transplantation now almost over 15 years ago, we would quote people, oh, your risk of rejection in the first year is about 20%. And it's probably much lower than that. And in fact, that's what we're seeing in Canada. And when we're looking at the types of rejection in Canada, we know that the risk of rejection from antibody-mediated rejection is probably closer to about 4% or so. So that's actually good news. But make no mistake, June also highlighted another part that was important that really stood out to me. She talked about the disappointment when she found out that for the kidney transplant that she was lined up to get from a living donor, that there was an antibody. And, we do know that if you have an antibody before transplantation, that recognizes if you as a person have an antibody as a recipient before transplantation because of transfusion, which has out of all the things that can cause antibodies, has the least effect in terms of causing antibodies. Pregnancy, which is a strong stimulus to your immune system and can cause long-lasting antibodies. Previous transplant, which is also one of the strongest stimulus, or even sometimes infections. So infections that we don't sometimes think about can stimulate antibodies that were not there on a previous test, but are there now. We know that if you have an antibody that can recognize your donor's kidney, that your risk of rejection is going to be much higher than the 11 to 13% that I quoted that we're seeing in Canada across the board. So those are the major areas that can lead to kidney loss. Of course, being compliant with medications is really important. And sometimes people have every intention to be compliant, but because of various things, like they have low white blood cell counts and we have to adjust medications down, there might be social factors, financial factors, many things that can lead to people not being able to be compliant with medications. And this opens up the door for immune injury to the kidney transplant. I think the very last thing I wanted to touch upon is calcineurin inhibitor toxicity. June also mentioned this, that her medications became toxic for her. And in fact, when you have issues with, for example, if you're sick in other ways, or if you have problems with your gastrointestinal symptoms like diarrhea or other things, sometimes that can make your levels go too high, and other times it can affect, how effective your levels are. And when calcineurin inhibitor levels are too high or too low, both of them can lead to toxicity and damage to the kidney. So this is why after transplantation, everyone is, asked to be very on top of doing blood work so we can monitor immunosuppressive levels. So, we've walked through now really causes of graft failure and loss. And we've talked a little bit about the natural history of kidney transplantation and how, kidney transplantation is not a cure, but it is something that will improve quality of life and in most cases quantity of life, and is certainly something that we know compared to dialysis, not only is it better quality of life, but it could be a better quantity of life. And I think June did a really nice job of expressing, the difficulty she's been having on dialysis. So the last piece I wanted to talk about, which we kind of touched upon, was living and deceased donor kidney transplantation, and really the difference between the two. And I'm just going to spend a little bit of time on this because I hope that, as Dr. Kim pointed out, at our second seminar, maybe we can talk about some of the new initiatives that are coming to kind of open up the door for further transplantation. Again, I'm going back to June's presentation, but she said, the kidney paired exchange program had just started, and she had mentioned 2010, and she's absolutely right. The first kidney paired donation that occurred in Canada happened in 2009, where people that were blood group incompatible or HLA incompatible because the recipient had an antibody that recognized their donor kidney. That program opened up, and there's lots of opportunity there, as well as our HSP program and something called Willing to Cross. But we're going to save that for another day. That's just a taster. What I wanted to say today is really that when we think about living and deceased donor transplantation, both of them are favorable if you are strong enough to go through transplantation, because you need to have I always say enough reserve to get through transplant, not only the surgery, but the medications or immunosuppression that we're going to be providing. But if you're strong enough to get through transplant, we know that the effect on your quantity of life and quality of life, there's no other intervention in medicine that I can think of. I always challenge people to say, think of one more thing that could decrease your risk of death by up to 2/3 in medicine. And we're very hard pressed to find that, right? The only other thing I would say is if you were needing dialysis and you chose not to do it, compared to going on dialysis, that would be comparable. But if you were to compare the same exact person on dialysis and the same exact person proceeding with a transplant would be preferable. And if we had a choice, which sometimes we don't have a choice, we have to proceed with what's available at the time. But if there was a choice, a living donor transplant gives us many options that are favorable, in that we can proceed on our own timeline. We know that wait times for deceased donors vary according to blood group. and we have to wait on a deceased donor wait list, and waiting on dialysis sometimes can take a very long time, sometimes up to 6 to 7 years for a blood group O recipient. And so we have the flexibility of being able to control when we're going to proceed to transplant with a living donor. And there's also benefits to proceeding with a living donor in terms of longevity of the kidney, and also being able to perhaps proceed before even starting dialysis if it's the first transplant, because we know that preemptive transplant before starting dialysis has a bigger effect in terms of positive health effects on survival of the kidney and the person than if you were to get transplanted while being on dialysis for a long period of time. So the take-home messages here are that, you know, in terms of mode of renal replacement therapy, transplantation is something that we're all very, very excited to participate in and help patients through because of the quality of life and quantity of life benefits. Transplant is not a cure. It is something that eventually, at least in this day and age, we haven't yet been able to kind of move the needle to a large extent yet in terms of the longevity of a kidney transplant, whether it be deceased donor or living donor. But it is something that, you know, we work together as a village to ensure that we get you a transplant that will give you the opportunity to enjoy a better quality and quantity of life together. And I think that's all I wanted to say. But again, I just really wanted to thank all the participants, and thank you very much for inviting me to speak today.
Thank you, Dr. Ribic. That was great. A wonderful overview. A lot of potentially complicated topics, but very nicely laid out. And again, to the audience members, if you have any questions, please don't hesitate to enter them into the Q&A. And we hope to expand on some of these topics further in November when we have our second session. So again, thank you, Dr. Ribic. So our final speaker is Dr. Vincent Key, and Dr. Key is a nephrologist based at Trillium Health Partners. And as I mentioned earlier, not only does he have extensive experience in the management of chronic kidney disease patients and dialysis patients, but he also manages at his own clinic and collaborates with us from the transplant centers a number of kidney transplant patients as well. So has some direct experience with this issue of a patient with transplant whose function may be declining, and what the transitions and other sort of challenges that are faced in that context. So I'd love to hear from him about his insights in this regard. So thank you, Dr. Key, for being here, and take it away.
Hi, everybody, and thanks, Dr. Kim, for the introduction. So as already introduced, my name is Vince Key, and I am a local nephrologist here in Mississauga. So my main focus is general nephrology, but I do have a side interest in renal transplantation. Just as a side note, I did do my training actually under Dr. Ribic, so I am very honored to be here with her doing this discussion on a very important and unique topic. I do want to first off apologize for my background. I am a little jealous that I couldn't get my Microsoft Teams to work properly for me, so I'm jealous that everybody else has a great background and mine's a little bit blurred, so I apologize for that. But more importantly, I do want to thank June. June, you share such a touching and emotional story today, and I think it was very brave of you to share it with us. And I think it's very definitely raises a lot of good points and questions for everybody to think about. And I also want to say, Sandra, I think I really admire your point that the word failing in this circumstance really probably doesn't serve properly in describing this journey, because I do think, June, you did very well, and you can hear it in your story and all efforts you put into trying to keep your kidney going. We definitely know that you worked hard, and it sounds like your team did too, to try and get that kidney to function long and well for you. And as Dr. Ribic said, it is unfortunate at this point that we still haven't yet figured out how to keep a transplant going forever. And that's why we do say this is definitely not a cure for the problem, but another option, but one that's very good in providing quality and quantity of life, and also having the ability to now avoid the need for dialysis within there. So I do want to thank you all before me for all the points that you have raised. So what I want to do is kind of give you a little bit of a perspective on the local nephrologist's experience in managing patients like June. Also want to give a little bit of my own perspective as to how I see a kidney transplant that is starting to lose its function. As the title implies, the title of this whole talk is Life After Losing Kidney Transplant. In a way, it's a good thing to know that this process does take time, and it is a process, and it's not something that just happens overnight. It would be quite a shock if kidneys failed that quickly, although in very rare circumstances that can happen, but usually associated with some acute illness. But for the most part, we know we can actually see and watch a kidney and know when it's starting to worsen. And so this gives us time to work it up and try and manage the kidney. And as Dr. Ribic clearly stated, it does take a team effort or a village to manage these patients. And I think when you link up villages, so transplant teams with our local kidney centers, we start creating renal empires. And so I think we actually have empires managing patients with kidney transplant. I think it's absolutely necessary to ensure things go as well as possible. Here in Mississauga, we actually manage our patients in our multi-care kidney clinic, and it sounds like it's similar in a way in London. And this is basically our multidisciplinary team approach, and I think that's absolutely necessary to ensure that we do fully cover the care required for our patients. Now, for many of you, this is probably a very familiar place too, because this is where we also manage people with advancing kidney disease. And I guess in a way, having a transplant is not very different, because it is a kidney after all. So when the kidney function is worsening, we're still managing chronic kidney dysfunction. The added difference here is that when it comes to a kidney transplant, there's now additional reasons and that need to be worked up as to potentially why the transplant is worsening. And Dr. Ribic has very clearly outlined some of the more common reasons. And this is one of the reasons why it is important that we do collaborate locally with transplant teams. As Dr. Kim mentioned, here I do collaborate, and my colleagues here in Mississauga, we do collaborate with renal transplant teams, because we do need the expertise to help us figure out whether there is a direct transplant-related problem that may be causing the transplant to worsen in function, or could there be something more typical that we know of that may be causing the kidney function to go down. And so it is a very collaborative process that's important. A lot of times, so here when we manage patients, sometimes we manage transplant patients not too long after they've gotten their transplant. So we see them maybe a year after their transplant, and we co-manage them in our clinic. And it's always very nice up front. You see the kidneys doing well, patients are very stable, doing well. Things really start to get stressful when we start seeing a creatinine starting to climb. And that's for sure an issue of concern for patients, but I also want to say it also brings great concern and worry to the doctor and the entire caring team, because we have a lot vested into the survival of a kidney transplant, and we want to make sure that we deal with any potential problems that may come up that may be affecting the function of the transplant. So when we do see a creatinine rise, we're all kind of up in arms and starting to think, okay, what are the potential causes? And Of course, it's easy to think, oh, this is a transplant and immune-related reason, but there are a lot of things that we can do here to kind of look into issues. So, for instance, in June's case, she had at one point diarrhea. So we do look at volume status. Sometimes it's as simple as being dehydrated. We would assess patients' volume status, especially now in our summer being so hot. It's not unreasonable that people may fall behind in their fluid intake and become dehydrated, and as a result, kidney function can get worse. So we try to manage that by educating patients about keeping hydrated, avoiding being in the heat for too long if they have no access to water. So that would be something that we can identify and manage here locally. Maybe there is an infection that's happening, whether it be viral or bacterial, maybe a pneumonia, urinary tract infection, that we can manage those. We look for those things as well too as a potential cause. Other common things include maybe blood pressures are a little bit low. So we have pharmacists and our team looking at medications to see maybe we have too many medications on board that may be affecting blood pressure, causing it to be a little bit low. So we can make adjustments in our clinic and get patients back to normal blood pressures so that the kidney is happier. And then we also manage infections if they occur. We also do locally assess medication levels. So just as Dr. Ribik mentioned, it is important to keep an eye on the medicines such as the tacrolimus and cyclosporin that most patients have within their regimen, and keeping those doses within target level, both to keep the kidney well, but also to avoid the toxic side effects of the medications. And we can do that locally as well. But when we've exhausted these kind of common causes, that's when that team and collaborative approach is important, where then I can reach out to doctors like Dr. Ribik and Dr. Kim with questions. I'm certain they're about to put a blocker on my cell phone because I do call them quite a bit, probably Dr. Ribik more so because she's so close. But it is important. I feel very blessed and fortunate to have access to such expertise at the click of a button to help me manage these patients together. And yeah, so that's definitely one of the benefits of having a team approach, that we can address a lot of issues together. Now, the other important thing with regards to local management of patients with worsening kidney function is that, remember, as I mentioned earlier, a kidney transplant that's worsening is in a way a kidney worsening. So there are a lot of kidney issues that can arise during that process. When I talk about managing kidney disease, I always teach about what I call the three pillars of kidney care. And the first pillar would be, what can I do to try and optimize the function of a kidney? And the second pillar would be, how do I optimize the vascular health or the blood vessel health to avoid blood vessel issues, which is so common among patients with kidney disease? And then the third pillar is, are there any complications from worsening kidney function that I have to manage? And this is the specialty of the multi-care kidney clinic, and that is what we do. We manage all aspects of the chronic kidney disease spectrum to ensure that these issues are stable and that things are done to kind of protect kidney function. So with the transplant, yes, it's important to absolutely ensure that the immune suppression medications are well dosed and patients are taking them properly. But there are other issues that can arise. Other diseases may still be present, like diabetes, like hypertension, that need to be managed aggressively, because those things can also affect the lifespan of a kidney transplant. So here in our clinic, our team is working on ensuring blood pressure is controlled, working on diabetes, and looking at the medications to ensure that the medicines we use also can help protect kidney function. over the course of the kidney health. And then we look at things like heart health and blood vessel health. So do patients have any issues with their heart? Are they having chest pains? Are they having signs that the heart is not so strong? Because as you know, the kidney depends on blood flow to be well, and the heart is the ultimate source of blood flow to the entire organ. So we want to make sure our patients' heart and blood vessel health is good. And then if there are issues that arise, we can refer them quickly for management and optimization. And finally, the complications with regards to kidney disease are many, as many of you know. So things like anemia, things like their electrolyte balances, making sure the sodiums, the potassiums, and the bicarbonate are all intact. This is something we do regularly with non-transplant patients, but it is still just as important to manage these issues when a patient has a kidney transplant, because these are all things that can affect patients' quality of life, and more importantly, it can affect how well that transplant will function over time. Now, I kind of want to spend the next little bit talking about kind of my own perspective too with regards to this matter. I feel every time, I don't think I ever am not impressed when I hear stories just like June's. They're very difficult stories because they do happen. And as mentioned earlier, I think creatinine rise is a very stressful thing for our patients, but for the team as well, it does worry us because we have an obligation. We feel very strongly in trying to protect kidney function, and as kidney doctors, that's our goal. Our goal is to really protect kidney function. We don't like dialysis just as much as any patient does. And so when we do see creatinine rise, and especially when the creatinine rises to the point of kidney failure, we ourselves feel quite distressed and upset because it sometimes feels like we didn't do enough. But I'm always I feel humbled because many a times when I'm caring for patients like June and others who have kidney failure, I always see such courage and bravery. And I feel supported actually also by my patients going through the journey. And that's really important. I think it's not just collaborative between health professionals. I think there's a very strong collaboration between patient and care team and the trust that we feel. And so we want to go the extra step where possible to try and see if we can keep stable kidney function and keep well all of our patients. As a patient with a failing transplant, especially when they're going through MCKC, one of the other things I have to acknowledge is it must also be quite challenging, extra challenging, because for many of you, it's probably the second time at least that you're going through the process again. Many patients have already gone through it once before they either started dialysis and then get a transplant. Some people may even be going through it a third time if they've already had a transplant once, and this is the second or third transplant that may be failing. So there must be a lot. There is definitely, and I can't imagine, a lot more emotional stress going through it. But one comment I do want to make, and it's been brought up before, is that many patients do feel guilt. And it's very obvious when you're managing these people. And we spend a lot of time talking about this, and it really shouldn't be guilt that you feel. I think you as a patient have done really well to keep your kidney going well for such a long time. And June, you are no different. You've done super well to keep your kidney going for such a long time, and you should be proud of that. I'm certain your care team, I'm certain even your donor is very happy with the result that you achieved with your transplant. And as noted, unfortunately, yeah, transplant is just another treatment option in the case of kidney failure and not necessarily a cure. And so, yeah, so we do spend a lot of time kind of helping our patients understand this and supporting them in this matter. So I think that's probably where I'm going to finish today talking about our perspective, and we'll move on to our next section. Thank you for listening.
Thank you, Dr. Key. That was really helpful, and I think these various perspectives provide different lenses to see this issue, and hopefully our audience members are reaping the rewards of these fantastic perspectives of both our patients, our care teams, and specifically our transplant and general nephrologists who are all involved in the care of patients. So this is now the Q&A section, and so I'm just going to ask the speakers to come on, turn on their cameras. There's a number of questions actually in the Q&A currently. I'm going to go in order in terms of when they were entered, and actually, June, I'll start off with you. There's a question from Craig asking a really important one, and of course a very personal one, and that relates to your resilience. How have you been able to get through the various challenges you faced, and how do you stay as strong as you do, is what Craig has asked you. So please.
Well, I think as a peer support person, a lot of us talk, especially facilitators, talk about how resilient kidney patients are. There's so much that we go through. Nobody, unless you're on dialysis, it's like somebody going through cancer. I can't talk about anybody going through cancer because I haven't gone through it. Even as doctors, you can see what we go through, but you can't feel what we're going through. I think the one person who does see what I go through all the time is my husband, and he realizes how tough it can be. Now, that's not to say that I'm always upbeat, because I'm not. I feel I've been kicked down so many times because there's things that have gone wrong. But my husband made this comment many, many moons ago to me. And he said, you know, June, you can visit Pity Village, just don't move there. So every once in a while I might get down and I'll say to him, listen, I'm just visiting. I'm not moving, I'm just visiting. So, you know, kidney patients are tough patients. And I think I'm just one of those tough people. And just tell you one more thing is, so my mother was actually pregnant 16 times. She had 7 miscarriages. So when I was born, my size was 6'6". I was the little runt. And so when my family found out that I was O positive and they were all B positive, of course, the first thing they said to me was, you probably should have been a miscarriage. Maybe I should have been, I don't know. But you know what? I survived that. I can survive anything. So that's my answer to Craig.
Thank you, June. I love that story about visiting and not staying in Pity Village. That's fantastic. But you know, when you're in the midst of it, it's hard to think of anything else. So it's completely understandable, and we just have to acknowledge that we feel the way we do, and there's a good reason for that. And so I think, and then I'm sure, as you said, the supports that you have been tremendously important as well. So it's important not to go through this alone. Thank you. The second question actually will be directed towards Dr. Ribic, the question around blood transfusions and its effect on receiving a transplant, Dr. Ribic. So there's a question in particular that Judy asked here about her husband who's received multiple blood transfusions for various reasons in the past, and has asked, could this potentially affect his potential for transplant in the future?
Great question. So, you know, the short answer to this is maybe. So we know that, unfortunately or fortunately, everyone has a different immune system. And when we think of sensitizing events, this is what this is called. This is something that your husband has had. We talked about blood transfusion, pregnancy, previous transplant or infection that can stimulate antibodies. Out of the three big ones, blood transfusion, pregnancy, or previous transplant, transfusions are the ones that are least likely to stimulate the immune system and make antibodies. It doesn't mean they can't, but everybody's different. We have some patients that have had multiple blood transfusions and it barely changes any of their antibodies. And other people have had, just a couple transfusions and they develop many, many antibodies. So the key here to answer that question directly and specifically for your husband is to do an antibody test on him through your HLA lab, your histocompatibility laboratory. But as I said, it's out of all the stimulating events, it's less likely. If he had 30 or more blood transfusions, we need to really obviously see if there's been an impact.
Great, thank you, Dr. Ribic. Yeah, it's definitely a bit of a complicated topic, but nevertheless, I think there are ways to try to measure this. And as Dr. Ribic said, everyone's a little different. So I think we would have to assess that to make a determination about how likely this will be a challenge. There's a direct question from Stephen to Dr. Key around the coordination of transplant patient care in your MCKC. So there's a question around, Stephen wasn't aware that MCKCs are involved in the follow-up of transplant patients. So just because she's being followed by his nephrologist in their nephrologist's office. So just a general question around what the organization or structure of follow-up care in your clinic specifically for the transplant patient.
Yeah, so I think even Sandra brought this up as well too. If you go across the nation, not let alone our own province, the approach to caring for a kidney transplant patient is quite variable. So yes, some doctors do manage their patients in their own clinics, and a lot of times it's probably because their kidneys are very, very stable, and there's not very many active issues going on besides managing the transplant. Here in Mississauga, we made a decision to house our kidney patients in our MCKC so that we do have access to our nursing care, pharmacy care, and allied team. And it's worked out well for us, and we've done this for several years. And it also allows us access to some of the resources such as blood testing so that we can actually test drug levels as well too. Yeah, so there is definitely a potpourri of approaches to the management of kidney patients. And I think you do raise a good point. Maybe in the future, we need to look as a province, at least in terms of standardizing how we manage patients once they are transplanted.
Great, thank you, Dr. Key. And I guess the next question is really, so Craig asked the same question around transplant specifically, but in terms of the approach. So when patients are coming into and exploring transplant, do they really understand or sort of appreciate the potential for rejection or failure in the future? Because that doesn't seem to be part of the discussions. And he makes a point here that he felt that there was really only the good news and not much in the way of sort of what could go wrong. And so how could we better articulate that to patients? And so maybe actually I'll ask Sandra to approach this a little bit, because I think you may have some of these preliminary discussions with patients as they're looking at modality selections and transplant being one of them. And then maybe I'll also ask Dr. Ribic and her experience as well as a transplant nephrologist. Sandra, please.
Thank you, Dr. Kim. So when we first meet people in the multi-care kidney clinic, some people may find it surprising that we have to tell people their kidneys are like their heart. They need kidney function in order to survive. And the reason I say that is a lot of patients don't realize that. And so I compare that to the conversation we have with them about transplant. Sometimes being brutally honest doesn't seem nice, but we do have to tell people and repeat the message frequently that, transplant is a treatment option. It's like the treatment option of dialysis. It is not a cure for what caused your kidneys not to work properly. And I think, when transplant comes, like we've heard from June and some of the physicians today, it's such an exciting time that there's this almost like a transplant high. I've received my transplant and things are now changing for me. And sometimes a lot of the discussions that have occurred already in the multi-care kidney clinic can be forgotten because people go from a state of not feeling as well as potentially they could on dialysis to now having a new healthy kidney that's working so well. So even though it doesn't seem nice to reinforce that message, it is something that we have to do.
Rivik, anything to add to that?
I think Sandra summarized it quite nicely. I think one of the things that I would kind of point out is that there is actually studies done on this when if there's a discussion to be had and there's parts of the discussion that are positive and parts of the discussion that are negative, people hearing that discussion will tend to only hear the positive parts. And it's because that's, again, I said, as humans, we kind of want to focus on the positive. We hear the negative and say, oh yeah, maybe that's not going to be me, or we just don't want to deal with that because maybe we don't want to go to Pity Village even just to visit for a little bit, right, June? But it's human nature. So I think the key here is that if we know that, and there's actually literature to support that, the key is actually making sure that we don't give the message just once. We have to do it repeatedly. And we have to make sure that people have the opportunity to ask questions. And it's always a really good idea to have someone with you. That could be your second set of ears to make sure that they can kind of chime in and advocate for you and say, wait a minute. Can you back up a little bit and tell me about, that piece that you just mentioned? Because it's an overwhelming amount of information that you have to synthesize. And let's be honest, when you're not feeling well, because you're getting assessed for a kidney transplant, it's going to be harder to synthesize all that information, even if you were feeling at the top of your game.
Absolutely, that's a great point. Thank you. So I think here, just looking through the Q&As again. Actually, before I sort of do that, maybe I'll just ask one question that was on my mind as well, and specifically to June. June, where do you think? I know your care teams, both the transplant and the nephrology teams that have cared for you in your transitions. I have no doubt they did everything they can to support you. But do you think, in retrospect, are there areas that you think greater support for a patient like yourself at that time who was in the mid of a transition in that regard, from transplant to the next phase of your kidney journey? Do you think there could have been other supports or greater supports in certain areas that would have helped you further in retrospect?
So I just want to comment on one of the remarks. I'm sure my doctors told me that this was not a cure and it wasn't going to last. But Dr. Rubik is right. Like, do you think I listened to that? No way. I figured this kidney was mine for life, okay? And I did everything that I possibly could to keep it. But I think when that nurse had called me in, everything was done so quickly that, I talked to her, then I talked to the nurse practitioner, then I talked to the social worker. I was all by myself for this appointment because I just thought I was going in to see my nephrologist. And I think had I known the reason I was being called in, I would have had my husband with me or somebody. I have a sister who's a nurse. Even my sister brought her in with me to go through everything. And, I think back to when I was first starting dialysis. You get all these pamphlets about everything. But you don't read half them because you're so stunned that you're going on dialysis. Just like when I was losing my kidney, like I was completely in shock Because like I had said before, the first time my creatinine level was 600. I wasn't even at 400. So how could I be losing my kidney? Even though I knew, although the doctors never once told me I was losing my kidney, but I did know that my creatinine was rising. So that's a telltale sign for sure. And I knew that I was extremely sick. But then when I got a call one day, and it was from one of the nurses saying, look, it ends up you have drug-induced colitis from Cellcept. Get off that medication immediately. So I stopped it that day. And it's always mind over matter too. And it could have been one of these things. The next day, I think I felt great, thinking, oh my God, okay, they finally figured this out. But then just still lost my kidney. I'm not sure. The only thing I think that they could have done better was to let me know ahead of time that I was really losing it. And again, like Dr. Key talked about the fact that it's hard on the doctors too. And maybe that's why the doctors didn't call me in to talk to me, and it had to be the nurse. So I don't know. That's the only thing I can think of that would be better. But as far as my doctors, how they took care of me and everything else, fabulous. There's no complaints. And through dialysis and everything else, fabulous. I'm well taken care of.
Great. Thank you, June. Really appreciate that. And there was a question here, just be mindful of time, but this question here directed, I think, towards me, actually, about, how we sort of guide patients through that transition and how it actually makes the nephrologist feel. And I think it's a really good question that was brought up by one of the participants. I think from my perspective, we want to do what is sort of in the best interest, of course, of our patients, and at the same time grapple with our own feelings. There's no doubt about that. We're human beings in this process as well, and as mentioned already, not only do patients feel like they've sort of maybe failed their donor or did not do enough to ensure this kidney lasts as long as possible. We, as your transplant team, also share in those feelings as well, and sometimes we don't articulate it as well, but rest assured, we feel that same sense of loss as well. The one thing, though, with that we have to be always mindful of is to not let that sense of loss or even sense of guilt influence our decisions or help you to make those decisions in ways that ensures that we take those next steps in a timely manner, so that we don't sort of hang on too long, so to speak. So I think the goal here is to make sure that we put yourselves or patients at the center, ensure what is the best sort of next steps for the betterment of the patient and in preparation for that next transition. So I think that's something that we always have to remind ourselves. There's also another question here more generally around the issue of the time frame or the expected outcome of a transplant. And actually, one of our participants says, they were never told this, that a kidney would last 15 or 20 years or so forth. And so every center varies a little bit in terms of that discussion, but we are coming together more so to try to harmonize how we have those discussions with patients. One of the issues that sort of unfortunately was a challenge for us is that we didn't have a lot of really good data to support exactly what's happening at the center levels, but that's changing. So that we have now a national effort to completely revitalize our national data system, which will also be able to drill down to the level of centers, and now we'll be able to speak more specifically about the longevity of a kidney at, for example, at St. Joseph's or at UHN and so forth. So we think it'll be a very powerful tool for us to have discussions with patients. And so that's on the horizon and not too long from now, but nevertheless, something very, very important. And I think we should try to do so in a way that's consistent across different programs so patients are receiving similar messages. Okay, great. So I see that it's 1:28. So I'm going to, first and foremost, thank our amazing speakers. Thank you so much, all four of you. It was an outstanding discussion, and so grateful that you joined us and shared your insights. And also, before I transition this back to Sadia Beg, who's really the mastermind of all of this, I want to thank Sadia specifically for bringing the session together. I think it was a fantastic session, highly informative, and I hope the participants feel the same way. So Sadia, without further ado, I think I'll hand it over to you to close us off.
Thank you so much, Dr. Kim, and we appreciate all of you coming together and open and honestly sharing your thoughts and being so vulnerable. That's how we're going to work together and build, a bigger program and a better program across the province. So thank you. So a few things just to keep in mind that we have coming up. As Dr. Key and Dr. Kim and Dr. Ribic were mentioning, everyone was mentioning, we do have part 2 that we are scheduling for November. We don't have a set date yet, but we're working on it. So please look out for that email and that information. We also have some other really amazing webinars coming up. One is on tips to reduce financial stress of kidney disease. That one is on Tuesday, September the 12th from 12 to 1. And then we also have a really good one on building a mental wellness toolkit with chronic kidney disease. And that is in October. I believe it is the Wednesday, October the 13th. So again, please look out for all that information so that you can register and view all the information from those perspectives. The next thing I'd like to share is we do have an active Living for Life program. The new session is starting September 5th to December 15th. Free exercise program, and it's great. A lot of our patients go through it. It's for kidney patients at no cost by a registered kinesiologist. So if you are interested, you can always email us and we can give you the flyer, or email activelivingbbrampton@gmail.com and provide them with your info. And yes, I will send out an email to everyone registered today so you have all that information. Great exercise program. And then next, almost done, we have our kidney walk. So our kidney walk is a great way to spread awareness and give back to, those in the community, meet each other in the community with your renal staff. I know Dr. Key has his own team, Power of P, and some other people like June as well. So please check out kidney.ca or kidneywalk.ca and learn more about how you can register, donate, fundraise, and support your local community. And then last but not least, again, if you ever need peer support, if you ever want to talk to someone like June, who is one of our one-to-one peer support members, please do reach out to us. We're here to support. We're here to help. We have a lot more new support groups coming that are going to be in person, and new ones that we're creating, like a pregnancy one in January with Dr. Michelle Halunovich. So we're really, really excited to have all these great opportunities. And yes, the Kidney Walk is in person this year. So once again, thank you everyone for being here this afternoon, and hopefully we'll see you at the next webinar. Thank you. Bye.
Thanks all. Bye-bye.